Now, ostensibly, the American legislative process is designed to force consensus and compromise, and the ACA was no different. Apparently, we couldn't even agree on a name. Like any good compromise, however, it left no one happy, with shrill cries from the right and the left alleging it did far too much or far too little. So tonight we are fortunate to have Congressman Jason Altmire to help us make sense of this messy process and the messier rhetoric that has clouded the issue. Congressman Altmire is uniquely qualified to lead our discussion tonight. Congressman Altmire is Florida Blue's Senior Vice President for Public Policy and Community Engagement, where he is responsible for leading and managing Florida Blue's Government and Community Affairs organization, which includes oversight of the Florida Blue Foundation and the Florida Blue Center for Health Policy. Prior to joining Florida Blue in 2013, Congressman Altmire served 3 terms in Washington, D.C. as a United States Congressman. Congressman Altmire was something of a political unicorn, a bipartisan centrist, and one of the last that we've had in a while. He worked both sides of the aisle and shepherded 29 of his legislative initiatives into law. He spoke on the House floor more than 200 times and did not miss a vote in 5.5 years, and introduced a bill that gained the support of more co-sponsors than any other congressional bill in American history. He also led a civilian rescue mission to Haiti after the devastating 2010 earthquake. Before being elected to Congress, Congressman Altmire spent his career in the healthcare industry working for the University of Pittsburgh Medical Center, and before that at the Federation of American Hospitals in Washington, D.C. Congressman Altmire also served as adjunct professor with a focus on politics and policy at George Washington University, where he had previously received his master's degree in health administration. So he was uniquely qualified to help guide the process that created the ACA. A nationally recognized leader on healthcare policy, Altmire has appeared on a wide range of national television news programs and has been profiled by major news organizations including National Public Radio, Time Magazine, The Wall Street Journal, among others. Congressman Altmire's talk is co-sponsored by the H.N. and Francis C. Berger Institute for Work, Family, and Children at CMC. I'd like to remind you that audio and visual recording is strictly prohibited. Without further ado, please join me in welcoming Congressman Altmire to the Athenaeum.
Thank you. It is really nice to be here. I have worked with Carl Patton, who is here. Carl, raise your hand. He's in the back. Who is a 1994 graduate from Claremont, McKenna. And he has bragged about this school the whole time I've known him for 2.5 years. And I'm so glad that you invited me to be here because now I can see what all the fuss is about. And it is a wonderful campus. I'm so impressed by the students. And I'm so impressed by this forum that you have where you have speakers come in and you can share diverse opinions and have thoughtful conversations. It's a very unique circumstance. So I hope that you all appreciate the fact that you're doing something that almost no other college or university in the country gets to do. So I'm really excited to be here and I'm thankful for the opportunity to talk. And I'm going to talk a little bit about the ACA. A lot of you wanted me to get into politics too, and I'm going to save that for the Q&A. So if you want to ask any questions about the Congress or redistricting, I know you all are very involved in the redistricting process here in California. I have some opinions about that too. Happy to have those discussions. But when you think about the Affordable Care Act, and as Dante talked about, and thank you, Dante, for the wonderful introduction, when you think about the way that process played itself out and all of the discussion and debate, not just in the Congress, but in the country that occurred, it really leads you to believe that the outcome that we got was driven by a set of circumstances that was unprecedented in American history, because we have never passed such a monumental piece of social legislation with only one party voting. Not one voting for it, not one Republican vote to pass the ACA, purely a partisan vote. And that happened for a variety of reasons because the bipartisanship fell through. But it was an unprecedented circumstance, and it's still to this day the animosity lingers because of the way that process played itself out, regardless of what you think about the law itself. But when you think about where we are now, 5 years later, after the law was enacted. If you think about where the country was in the beginning of 2009 when the discussion on health care reform started, we had just, at the end of 2008, had 2 straight quarters with massive losses in GDP. The last quarter of 2008, minus 6.5% loss. in gross domestic product. The third quarter, minus 2.2%. We were in free fall. The average job loss was 750,000 jobs per month, every month, in the 6 months leading up to the turn of the year in 2009. That's what the economy looked like. So when the healthcare reform proposal was put forward, before it was called the ACA and before it was drafted, healthcare reform was put forward as an economic remedy, as something that's helping to drive these negative consequences that we're seeing, a near depression, a catastrophic circumstance in our economy. And healthcare was a part of that, because healthcare was the largest driver of bankruptcies in the country, the lack of health insurance. And healthcare costs are literally going to bankrupt the country if we don't do something about it. I continued to hear that. And when we talked about the economy. So we started the process thinking about the cost of healthcare and what are we going to do to bring down that cost. But we ended the discussion 14 months later in March of 2010 talking about covering everybody. What can we do to make sure everybody has coverage? Not talking so much anymore about lowering the cost of healthcare or increasing the quality of healthcare. So we ended up with a finished product that, as drafted before the Supreme Court struck the Medicaid provision, as drafted, it did a pretty good job of covering everybody. And I will touch on King versus Burwell, which I know a lot of you are interested in too. So why did that happen? Why did we take cost and quality off the table? There are some initiatives in there, and I will say the administration has done a very good job through regulation and administrative action of increasing the quality standards and through pay for performance, value-based purchasing measures, dealing with access as well as cost and quality. So it's better than it was in 2010. But the reason those were taken off the table was because they simply couldn't pass the bill without those special interests that are involved in the healthcare system, the doctors, the pharmacies, the medical device industry, the hospitals, consumers groups. All of those interest groups could have defeated President Obama's bill in the same way they defeated President Clinton's bill in 1993 and 4. So, not wanting that to happen, they postponed those difficult decisions, because the way you reduce the cost of health care is you make reform in the delivery system. And that's painful, and that's something those interest groups don't like. So they would have rebelled. So in order to take that off the table, they did a lot less of that than was initially proposed. So we ended up with a bill that covered everybody, to its credit. So what does that mean? What that means 5 years later now is that consumers have adapted, which I'm going to talk about, and providers have adapted, but the private sector, the private market, has worked together in a way that wasn't happening as much before. There were some leaders in the healthcare industry, but now, working together, you're starting to see the providers and the insurers work together instead of sitting across the negotiating table arguing over who's going to pay for what, which had always been the case. Now you're seeing them do a couple of things. One is get into each other's business, which I think as you see the healthcare system evolve in the private market, you're going to see a lot more of that, a lot more commingling of the insurance side and the provider side. Seeing private entities like Walmart and even Google, Microsoft get into healthcare in some way. And I'm going to talk about some of the technological advances that will lead to that. But you're going to see a lot more of the coming together because that's the way the private market has been driven. So the quality, the baton of quality and cost has been picked up by the private market, and now they're running down the track. So you're seeing it a lot here in California. In Florida, where I'm from, in Florida Blue, where I work, we're very much involved in leading the way on this in Florida, where you're seeing accountable care organizations, patient-centered medical homes, bundled payments, all the things that I know you've been talking about in your health policy classes. Those are real-world examples of things that are happening to have a transformation in our delivery system. So when we contract with a hospital through an accountable care organization, and we have 18 of them in Florida, or we contract with a patient-centered medical home network, and we have 2,700 physicians that are involved in our patient-centered medical homes, and that's about 750,000 lives that are covered in that. We do it based upon quality and cost, and we do predictive modeling. We work with the provider to try to determine what the cost that's appropriate for covering the population that they serve. We agree upon a target, and at the end of the year, if you've reduced the cost beyond what was expected, that's great, good job, but it's not enough. You have to have also increased the quality, or at least make sure the quality doesn't regress, keeping it the same or improving it, across a couple of dozen metrics that are used. And again, this happens all across the country, and it's happening here in California as well. So when you have that type of system, miraculously, it incentivizes collaboration. And for the first time, as I said, providers and physicians and hospitals are aligned on their incentive. And what's most exciting is who's the biggest winner in that? The biggest winner is the consumer, because you're getting higher quality health care at a lower cost. So it's driving competition in the market. It's driving innovation. And what you're starting to see, again, led in the private sector, is that innovation that's moving forward is transforming the healthcare system in ways that were inconceivable and seemed like science fiction only a few years ago. So you have payment reform that's driving the cost part of that. But you have innovation, and you have quality, and you have all of these things coming together in a way that increases competition and it empowers the consumer. So those are the three things now that we see moving forward: consumer empowerment, competition, and innovation. And what you're starting to see with competition is we need to compete based upon cost, not based upon how many bells and whistles you have, how many things you have at the hospital. And competition in the healthcare market used to be, if one hospital had a helicopter, the hospital across the street had to have 2 helicopters, which means the third hospital had to have 3. That type of competition does not drive cost reduction. It's the opposite of that. So competition not done well in the healthcare industry, in the healthcare market, doesn't work so well. So what you're seeing now is the proper kind of competition, and it leads to consumer empowerment. So transparency and control is something that is going to be universal across the healthcare system. Instead of the healthcare system being designed around the provider, the convenience of the physician and the hospital, it's going to be the exact opposite now. It's going to be designed around the convenience of the consumer, of the healthcare beneficiary. So when you see things like kiosks, self-service kiosks, we have one in one of our retail centers in South Florida where you can go into the kiosk and sit there and be connected to the Children's Hospital of Miami. So you don't have to drive through traffic to see that physician, and you don't have to wait in that waiting room. You go to the kiosk and you sign in, and there's a doctor in front of you, and you're sitting at the mall, right? That's a big difference. But what that's going to evolve into is control to the point where you're going to have on your phone the ability to connect with any physician that you want. And it's going to be, instead of saying, well, the doctor will see you now, it's going to be telling the doctor, the patient will see you now. And if you don't want to play in that world and you're not comfortable with that technology, you're not going to do very well as a healthcare provider. So you'll be able to connect on the iPhone directly to an available physician. You'll be able to have devices that monitor your vitals and your temperature and all the things that people look for. If you have diabetes, you can check your blood sugar, all of the things. And that's just the first step. So it's going to be much more about giving the consumer the ability to control their own destiny, to control their access, and to control their own health, because prevention is the key to the whole thing, preventing people from getting sick in the first place. Now, what you have to avoid and be careful of, I told you about the wrong type of competition. There's also the wrong type of consumer empowerment. So when you see this direct-to-consumer marketing, commercials on TV where they encourage the consumer to go to the doctor and tell them what type of prescription drug they want. Or you're driving down the highway and you see the sign that says, we're an emergency room and we'll see you in 5 minutes. Our wait is 5 minutes. What they don't tell you is it's going to cost 3 times more, and it's one of the least efficient settings where you can get your health care. You'd be better off going somewhere else. But if the consumer is not well educated, then if they make bad decisions, that doesn't help anyone. It doesn't help them, and it doesn't help the cost and quality aspects that we're talking about. We want to help consumers make good choices. And competition sometimes can drive costs the wrong way, but I want you to consider an example and what it means for the insurance industry of how it works the right way. Right now, you don't have transparency. And when you talk about empowering the consumer, we're talking about giving them the ability to cross-reference pricing and outcomes and know when they go to a provider whether or not they're giving good quality. So those measurements and those metrics that I talked about earlier, making sure that providers are doing the appropriate things and being reimbursed based upon not the quantity of care, but the quality of care that they are offering. Moving away from a fee-for-service system where every time you show up at the doctor, every test they run, every procedure they order, they make more money, into a system where instead we're reimbursing based upon keeping you healthy and keeping you well and out of the system. That's what it's supposed to be about. But you can't operate in that system to the benefit of the consumer completely until the consumer has transparency, until you're able to comparison shop. And you know when you need a knee surgery and you have 6 hospitals that can do it, which one has the best outcomes and which one has the lowest cost, and make your decision based upon that. Not just letting it go, and they're going to bill the insurance company, and I'm going to pay 20%, whatever it is, and that's that. So adding transparency in competition dramatically reduces cost. And think about this example. LASIK, eye surgery, used to be outrageously, almost prohibitively expensive years ago. Technology continues to get better. They're doing it better, more innovative ways, faster recovery time, better outcomes, higher technology, and lower costs. It's not always the case in healthcare. Often, higher technology means higher cost. Better technology means higher cost. Well, why is it different with LASIK? Why has the cost come down so much while the technology has improved so much? Well, it's pretty simple. LASIK's not covered by insurance. You're paying out of your own pocket for the most part. So you're very sensitive to the price. When you have private insurance and you show up and you don't know what the cost is, and it's all the same and you have no way to check until they send you that bill at the end, that's a very different set of circumstances. So transparency is going to transform, it's going to revolutionize the way the consumer is empowered in the healthcare marketplace. So when you have an app, we have an app, a lot of healthcare providers have an app, and you press your Find a Doctor link and it GPSes you and says there are 15 physicians that will serve you within your region based upon whatever treatment you're looking for, whatever specialty. We want to get to a point where you can have a way to then click on those physicians or hospitals and say, well, let's do some comparison shopping on these measures that I'm talking about. That's the direction that we're going. So all of this leads to incredible innovation. And I told you about the science fiction nature of what we're able to do and the things that are on the drawing board moving into the future. And when you consider all of the research that's being done, the genome, stem cells, regeneration, 3D printing, which is miraculous, genetic modification, all of these things are going to transform the way you think about medicine in this country. It's amazing. You remember Star Trek with the tricoder, right? Where Bones McCoy would wave it over the body of the patient and it would tell you all the things that were wrong. We're actually not that far from that. That's a national research race that's going on to be the first one to come with that. And it's not even inconceivable anymore. When I say that to you, you think, yeah, okay, I can kind of see how that would work. Well, that's the direction that we're going, those type of benefits. So think about what this means in the market. When I talk about 3D printing, they're going to be able shortly to do things. They've already done it with things like esophaguses, the less complicated body parts. But transplants, if you need a new kidney or pancreas or liver, they take your DNA and they print up a new liver with your DNA. And they put it in you. No waiting list, which is its own problem, no fear of rejection, all of that. Those are the types of things moving forward that we're going to be able to do. They're looking at being able to inject into your bloodstream things the size of a blood cell that will seek out things like cancer before you know you have it and before it's detectable, and kill it. Anything that's bad floating through your body that will be able to alert you that you have a predisposition to something that you wouldn't have known about for 10 or 15 years. And it'll be immediately sent to somewhere where they'll be able to diagnose that and put you on the right course of treatment. So those are the things that we're moving to in the future. Being able to repair burns by, again, printing up new skin from your own DNA. Broken bones, being able to make them heal quicker with the same type of technology. This is where we're going in the country. So when you think about that, you think about what does that mean for public health? And one of the things that they can already do, think about texting when you text, or when you search on Google, or when you send emails. They're experimenting with ways that we could track the words that people use. So if you Google Tamiflu or symptoms of the flu in a region, you can see that, hey, maybe there's an outbreak because there's a hot spot there. Those are the kind of things we can already do. And you modify that to text, and the way that that would operate, again, revolutionizes the way we think about public health and prevention. So where are we going with all this, right? What are the options? And that's the problem. When you think about how our money is spent on research and where we're focusing our attention on research, right now, a lot of that money is going towards thinking about life expectancy and aging. And that's certainly a worthy cause. When you think about where life expectancy was in 1900, the leading causes of death in 1900 were tuberculosis, pneumonia, and influenza. Well, today, those are still a problem, but not nearly what they were in 1900. Today, it's, of course, cancer and heart disease. So you don't want to go down the road of researching and just changing the way you die from one thing to another, but you want to extend life expectancy. But what is the cost of doing that? Not just the monetary cost, but the social cost. What are the unintended consequences of that? And there are some who argue that because of, life expectancy at the turn of the century was 50. I told you about what the causes of death were. Average life expectancy was 50. Today it's 80. So we've made tremendous progress in 115 years on extending life expectancy. There are some who argue in the scientific community that we are about to go in the other direction because of the obesity epidemic in this country. And there's some merit to that argument, although there's enough focus on it and enough being done to change that. But in the year 2047, for the first time, seniors, people aged 65, are going to surpass the number of children globally. First time, because of the aging population. So if you think about all of that, there are a lot of unintended consequences to research going into that. What about some of these countries? We have 2.5 billion people on the planet, 2.5 billion people that do not have access to non-contaminated water, to sanitary water, sanitized water. 2.5 billion people, 1/3 of the planet's population. Should maybe we consider spending some money on that, on helping those people, which are pretty simple solutions if you can help them get there? How about helping some of the people in the world who don't have enough food by helping them get fertilizer and proper agriculture techniques? Those are some things that we could do. So there are consequences to the way that we're spending our money. But think about the cost of keeping people alive longer, which is a good thing. And people are going to live routinely as things progress, maybe to 150. That's the goal. That's what you hear about when you look at the research community. And if people live to 150, well, what does that mean? Again, forget about the ethical consequences of focusing research in that direction instead of the other things I was talking about. If you live to 150, what does that mean? Well, what does it mean for society with our resources, with our food programs, the natural resources, if you have so many people on the planet? What does it mean to our federal budget in America if you have people retire at age 65 and then live to 150? Now let me throw a stat at you, a statistic. 1/3 of Medicare beneficiaries, 1/3, well, let me say it this way. Medicare is funded by a payroll tax. So you pay into the payroll tax 1.65% matched by your employer over the course of your entire lifetime. Over the course of your entire lifetime, and then you retire at age 65. So currently, the average Medicare beneficiary gets back all of that money, uses in the healthcare system every penny that they paid into the system in their entire lifetime within the first 3 years of retirement. So at age 68, they're now on the negative. And guess what? They're going to live to 95 or more, which is a good thing, right? People are going to live longer. But what are the budget consequences? 1/3 of Medicare beneficiaries use every penny that they've paid in over the course of their entire lifetime within the first year of retirement. Those are the sickest patients. That's a problem, especially if people are going to live to 150. It's actuarially unsound, to say the least. It can't continue. What does it mean for the Social Security system? Think about the budget implications of this. What is going to be the cost of covering these people? What are going to be the insurance consequences? So yes, we can prevent them from getting sick. We can delay the onset of diseases. We can do the organ transplantation and the joint repair that I talked about. But all of that costs money. Fixing the problem is a lot more expensive than preventing the problem. And there's going to be an insurance component to that. The people who have insurance are going to have to pay for the offset of that. And if it's in the Medicare program here in America, it's not sustainable. So think about it as Niagara Falls, right? It's a lot easier to prevent people from going over the falls in the first place than paying money to solve the problem after they've already gone over the falls, right? Put up a guardrail and maybe a sign that says stay out of the water. That's a lot simpler and less expensive, a lot more simple and less expensive than retrieving what's left after they go over the falls and having to deal with that. Healthcare is the same way. It drives added expense when you're fixing the problem. So if people live longer, the lagging indicator in the research is the mental capacity. So right now, 1/3 of the people who are over age 85 have Alzheimer's or dementia. Again, what happens when you live to 150? And if you don't solve that problem while you are solving the physical problem, where you're making people physically healthy, but you haven't solved the mental issues, that creates a whole other set of circumstances. So think about that part of it. So what about, even if you do solve that issue and people live longer, what do you do about corporate CEOs who are feeling pretty good today? And they're going to be feeling pretty good for the next 25 or 30 or 40 years. And they want to stay in that job. And they're doing a great job. But what about the younger generation that's coming up that wants to advance up in their careers? How many jobs are available? What does that do? What does it do for just the way people live their lives, for the incentives that they have, and giving to charities and supporting their families and doing things that they do and looking forward to retirement and just the personal motivations people have? All of that changes. What do you do about politicians? You're tired, you want term limits. A couple of you talked to me about term limits. What about these career politicians? What if you could serve 12 terms in the United States Senate? What if you had somebody 130 years old sitting in the United States Senate? So these are things that are a ways off. But when you're devoting billions of dollars in research, you ought to be thinking about that stuff. Again, while you're letting some other problems go unsolved. Social changes. What about personal savings for people? How much money do you have to live on retirement? If you're going to retire in your 60s, 70s, even 80s, but you're going to live for decades more, you need to make sure you have enough money to sustain that. And if you don't, there's a societal complication to that. The National Institute of Health, I want you to think about this, which is the federal funding arm for federal medical research, has been reduced by $3.5 billion in the last 5 years. 11% cut, adjusted for inflation, 11% reduction. And the NIH used to be 2/3 of the funding for medical research in this country, and 80% of NIH funding goes to colleges and universities for their medical research. So you should be very concerned about that, because who's now picked up that baton and is running down that track are the venture capitalists, the billionaires, the philanthropists. And it's a wonderful thing that we have people in this country that are willing to give hundreds of millions of dollars to causes like medical research. But when they decide they're going to focus their attention on immortality and living longer at the expense of other things that that money could have been directed to, there's a consequence to that. It's just something to think about. NIH funds medical research, all across the board based upon what the current needs are today. So think about all of that in the context of where we're going in the country and all of the unknowns that are in that. So I want to move into King versus Burwell really quickly, and then I will take questions. King versus Burwell, as all of you know, is the Supreme Court case which is going to be announced, it's already been heard, dealing with the subsidies on the exchanges for the ACA. Now, with regard to the 34 states, California not being one, that operate through the federal exchange, nobody in their right mind, nobody, could think that it was Congress's intent to exclude 34 states from the provisions of the ACA that required coverage, that helped coverage. So that was not where the Congress was going. Now, the law is very unclear. It basically says, in great detail of state exchanges. Here are the parameters. Here are the way the subsidies work. This is the way everything is supposed to flow through the state exchanges. This is how you set it up. And if your state decides not to set up an exchange, your citizens will run through the federal exchange, and then it goes on to talk about other things. So it never says, by the way, all those same rules apply. And if you're in a federal exchange, you still qualify for the subsidies. It doesn't say you don't, but it doesn't say you do. So the problem is in the interpretation. And if you're sitting on the Supreme Court, I don't know what the court is going to do. No one knows what those 9 justices are going to think about. But here's my opinion. You asked me for my opinion. I think that Justice Roberts, especially given that he voted to uphold the constitutionality of the law in the first place, in the first court case, I think he realizes he's going to be on the court for 40+ years as Chief Justice. And I doubt he wants his legacy to be overturning the biggest social policy that was enacted during his time as Chief Justice on a technicality. I don't think that's what he would want his legacy to be. But let's say, and Justice Kennedy is probably up in the air on this too, so it may be a 6-3 decision. But let's say it goes the other way. And let's say they decide that it's unclear and Congress didn't stipulate specifically that the subsidies qualify in the federal exchanges, so therefore they don't get it. So then what happens? A couple of things happen. One is it gets thrown back to Congress because it was Congress's mistake, and I'm sure in writing the opinion, the justices will reference the fact that Congress could fix the problem. Theoretically, they could easily fix the problem were it not for the dysfunction that is occurring in Congress. But just looking at the way the process is supposed to work, they could easily fix the problem. But then the states, those 34 states, most of them with Republican legislatures and governors, are going to probably at first be pleased with the result, but then they're going to realize that they now have, in Florida's case, 1.2 million people, and in other states, millions across the other states in America, people who all of a sudden have no health insurance. Because the average premium in the exchange in Florida, and I'm sure it's similar in other states, is almost $400 for people who bought through the exchange. The out-of-pocket costs for the individual is $90 a approximately. The rest is covered by the subsidy. So if you're going to increase the out-of-pocket cost from $90 to $400, it's unaffordable for people. They're simply not going to be able to afford it. So what are they going to do? They're not going to disappear. They're not going to throw their hands up and say, well, okay, I'll just go home now. I don't have health insurance anymore, and I had it for 2 years. They're going to march on their state capital, and they're going to go to Washington, and they're going to say, why did you do this to me? Why do my cousins in California have health insurance through the exchange, and I don't? Because of a political decision under the same law. It's not supposed to work that way. And unlike the Medicaid population, because if you're really cynical, the Medicaid population, some could look at and say, I kind of know how that population's going to vote, and I may or may not be worried about that vote going against me. You can't do that with the exchange population. The exchange population is diverse politically and in other ways. So when you look at that population, you can't make a political calculation and say, I don't need that group of people to win my election, so I'm not going to worry about that issue. You can't do that. And you're going to see those folks in church and in the grocery store and in your office, and you're going to wonder why you're in the predicament that you're in. So that's going to be a real public policy issue that's going to need to be dealt with. So I would leave you with that, thinking about it. I don't believe it's going to be overturned. I think that the court will rule in favor of the Burwell side. But if it's not, we go into open enrollment for the exchange this fall. And there is no state, almost no state, that can move quickly enough in a June decision to implement a state exchange in time for open enrollment in the fall. And there's no insurance company in the country that can change and modify accurately their decisions based upon that decision. So we're doing contingency planning like everybody else is, but that's something that is just going to totally have great upheaval in the healthcare market to the degree that we've probably never seen for the immediacy of it. So you'll, as people who watch public policy and think about healthcare policy, you're going to see a lot of really interesting things over the summer going into the fall if that decision is made. But it would be catastrophic in the implications it had in the private market for people who still have insurance and for people going through the exchange. So with that, I know we had a ton of questions, so I don't know who has the microphone. Here's the microphone. I would love to answer any questions you have either on healthcare or politics or whatever you want to talk about.
We will now have time for questions. If you do have a question, please raise your hand and either Joanne or I will come by with a microphone. As always, preference goes to students.
Thank you for your talk.
Sure.
So I was wondering about the opting out function of Obamacare because there was a recent study done, and now that people are enrolling, they have a lot of data on this.
Can you all hear his mic? Is his mic on? Hold it up.
So people are, now that they're enrolling, they have data on their decisions and how they enroll. And they've found that some individuals, when they are aware of the ability to opt out and pay a fine, that many are actually opting out and paying that fine, especially young people. So I was wondering what your thoughts are on if that's true and whether, what its implications are for the future of enrollment.
What's your first name?
My name's Ian.
Ian.
Ian, yes.
So he's talking about the, both, you're talking about the employer mandate and the individual mandate, right? Both. Okay, so the individual is required to have health insurance, this is the whole first Supreme Court argument, or they have to pay a tax. And he's suggesting that the individual would pay the tax instead of having health insurance. Well, that has bad consequences. If healthy people opt out of the system and the risk pool are all the sick people, you're going to have higher rates and it distorts. That's why the mandate exists. But when you have 2.5% of income be the penalty, the first year it was $95. So that was not much of a, or 1%. It was not much of an incentive. But when it's 2.5% of your income, that starts to be something you need to think about. And that starts to equate to the actual cost of having health insurance at that point. So it wouldn't be a wise decision for most people. But yeah, theoretically, most people, some people could do that. But I don't think over time they would continue to do that, unless they're unaware of the law, maybe paying taxes for the first time, but that would be a one-time mistake. The bigger issue is the employer market. Think about the employer penalty, which is $2,000 for employee. So if you're an employer sitting there, and you know in the exchange, especially in the urban markets, your employees, anyone operating in the exchange, choosing their health plan, can have literally more than 100 options, a dozen or more different carriers offering different levels of coverage, different packages, 100 different options or more if you go into the exchange. And you're going to get the subsidy, if the subsidy is not struck down. Then you have the employer, whose average cost per employee for a family health care plan is $12,000 to $15,000. That's the real cost. But you can pay a $2,000 penalty, put your employees in the exchange. They're going to have more choices in the market and probably less out-of-pocket cost because of the subsidy than you're able to offer them. And you're going to save yourself as a business somewhere between $10,000 and $12,000 per employee. What do you think people are going to do? What are employees going to do? Now, there's other reasons why employers offer health insurance, to attract and retain talent and make it a good benefit. But when the exchange got off to the horrific technological start it did in the fall of 2013, a lot of employers stepped back and said, I don't know if I want to get involved in this. But once it starts to be operational and the Supreme Court case is behind us and people are really comfortable with the law, I think it's generally accepted in the CBO when they score this and predict how many people are going to have coverage through the exchange. It's going to only grow. You're going to see that market where employers are providing insurance start to shrink and more people buying through the exchange. Who's got the mic? Okay.
Hi, thank you for your talk. I had a question when you're talking about the new way that healthcare will work with the patient not ready for the doctor, but the doctor ready for the patient.
Yeah.
What do you think the implications are for the care, the quality of care, once you flip the table on doctors? As a person who's spent a lot of time in hospitals, it's not fun to be waiting, but if you're waiting for high quality care, sometimes it's worth it. Is there any fear, I'd say, that the change would devalue the type of care that we get in this country? Thank you.
It's a good question. Obviously, we do not want to go in that direction, but the way you solve that problem, again, is by reimbursing based upon the quality of care. So if a physician is thinking about the way they're going to handle cases, and their reimbursement is based on keeping you healthy and out of the system, and they're part of a large group of people, and that group is going to be reimbursed based upon you staying healthy, they're going to pay a lot more attention to you. When they prescribe a prescription drug to you, and you walk out the door in a fee-for-service system, they don't really have an incentive whether or not you take the drug. You end up back in the office, they're going to make more money. But if their reimbursement is tied and they're penalized for you showing up with the same illness that was preventable, then they're going to be on the phone with you that night saying, hey, did you take that medicine? Are you doing those exercises that we talked about? It's really important that you do that. Simple example, but those are the kind of things that you're going to see moving forward. So I think the type of, the way that physicians and all healthcare providers look at the healthcare system and look at the way they're interacting with patients is going to change. So what you described is a possible outcome in the old system. If you just all of a sudden say you can access your provider at any time and you're going to go to the one that happens to be available right now. But in the new way of reimbursing based upon value, you're going to see a change in that, and I don't have as much of a concern about that.
Hi, thank you for your talk. So I'm interested in the legislative process. You mentioned earlier that a lot of people think the law went too far and some people don't think it went far enough. Obviously, not only was there, as you mentioned, heavy lobbying on both sides throughout the debate, but there's also special circumstances, including Scott Brown's election. So what do you think about the final result? Is it an ideal option? Do you think we'll ever have a single-payer system, and what do you see the future in terms of legislative side?
There's a lot of questions, a lot to work with, but they're good. The finished product, as I talked about, does not do enough on quality and cost, but it does do a lot on access. And we should have figured out a way to work the Medicaid issue better than we did, because that was not consistent with the law. So that's a big gap right now. But I think 5 years later, it would be impossible to look back and say that the strong critics of the bill who predicted doom and gloom and the sky is going to fall and it's going to be a catastrophe for the country, I think it'd be hard to say that that's been what's happened. I don't think any rational observer could say that. Most of the critics have proven to be very wrong. You know, my concerns were specific to the district that I represented, and they were specific to, again, the cost and quality aspect. I wasn't one of the ones who was out there predicting great doom and gloom. So I think as citizens we should root for our laws to succeed. We should not root for failure. I think there are people in the political system now that are rooting for failure, that are hoping people feel pain and things go wrong, maybe hoping that the Supreme Court rules the other way on King versus Burwell, so they can point and say, I see, I told you. But by and large, I think if you look at the way the law was supposed to play out, it's played out about as well as it could have. Now, with regard to the single-payer system, think about the public option. I talked to a fair amount of you earlier today about this. During the debate on the exchanges in the House bill, it was talked about to put an option in the exchange that would be a federal government-run health care system, health insurance program. So you would choose among United and Aetna and Cigna and Humana and Anthem, and you would have a federal government health insurance plan among your choices. An insurance plan that didn't have to meet the same actuarial standards, that could take huge losses and set their prices dramatically low, and the federal government would pay the losses. The equivalent of these old gas stations that used to set up shop across the street and offer gas at half price until the other guy closed, and then they would raise their prices back up. It would have driven all the private health plans out of the market because they couldn't possibly compete with a plan that didn't have to meet the same standards. It could take losses. So then, if that happens, until Medicaid was struck, you would theoretically have had Medicaid in the beginning, and then from 100 to 400% of poverty, you'd have the exchanges, which de facto would be the public option, a federal health care plan. And then on the other end, you'd have employer coverage, but then you'd have Medicare as people aged into it. So you'd almost have an entire healthcare system administered by the federal government, especially when you include the DOD and the VA. That did not sell. So I can give you a lot of policy reasons why I think a single-payer system is a bad idea. And there are many, and we can talk about that if you want. But it's really not worth thinking about from anything other than just having a fun talk, because it's politically unrealistic. Think about the political climate when the public option was talked about in 2009. Before Senator Kennedy died, the Democrats had a filibuster-proof majority in the Senate, 60 votes in the Senate. Could have done anything they wanted. The House had an 80-seat majority in the House, and we had a president who was probably willing to go along with whatever the Congress sent him at that time. And if the public option was so politically unpopular in that climate that the Congress couldn't get that through, there's no way they could take the step politically in today's world or any time in the near future to do something more than that, a complete government-run healthcare system. It's just not politically realistic. And it's not, it wouldn't be popular with the American people. Got one.
Hi. Can you? Oh, okay. I remember earlier in your talk you were talking a little bit about transparency, and you mentioned some things that could be harmful in terms of transparency, and I remember you mentioning direct-to-consumer advertising. So I guess I just wanted to talk a little bit about why the Affordable Care Act didn't do anything with regards to direct-to-consumer advertising, given all of the negative documented consequences, and that we and New Zealand are really the only ones that allow for it.
It was talked about. The prevailing view is that we live in a free country, and restricting the ability of companies to try to sell their product and inform consumers, theoretically informing consumers, is not something that we're comfortable with in a free society, right? But prescription drug advertising was greatly restricted before 1997. You wouldn't have seen any of these commercials where you see the guy riding the horse down the beach and you have no idea what this drug is, and then at the end it says the name, and you're supposed to go to your doctor and ask because you saw, you know, and that's the kind of, and then they take 30 seconds to outline all of the medical complications that can occur. Those aren't things that used to happen. So having the patient show up at the doctor's office and saying, I want this drug, may not be the best way of doing things. But you need, with the internet and the ability to research and find information, hopefully consumers will be well informed and use that information in a way that is to their benefit and can sift through some of the things that maybe are a little questionable.
Hi, Congressman. Thank you so much for your talk. In the beginning of your talk, you spoke a little bit about innovations that you guys at Blue Cross Blue Shield are working on in terms of, I guess, like healthcare apps and healthcare technology. And I was wondering if you could speak a little bit about how this system, in your view, is helpful or harmful to actual like medical research and progress, not just in terms of technology, but in terms of curing things and actual like healthcare.
Oh, yeah, well, all of the things, first of all, the app and that more current technology, right, that is about access. That's about prevention, keeping people well in advance. Because diabetes, for example, in some cases, not all, some cases is preventable. And if you can prevent the onset or at least delay the onset of diabetes, you have dramatically improved the life of that person, the quality of life, and their family, which is most important. But you've also saved a ton of money for the healthcare system, especially in the aggregate. And we do things, when you think about cost, that are pretty simple. The second largest cause of the increase in healthcare costs in the state of Florida is falls for seniors, broken hips, stuff like that. Well, those are very expensive to treat, and in some cases are fatal. So, as I said, the most important thing is the quality of life of the patient. If you can prevent that fall from happening, but you also save money, a lot of money, by preventing that from happening. So one of the things that we do is we will go into the home of a senior and sit down and say, here are some things you need to think about as far as reconfiguring your house, which in some cases we will help them pay for. We will also have a conversation about, hey, your balance isn't the same as it used to be. And here are some things that you can do to work on that. So those are some really simple things that aren't even that much about technology. But when you get into the future and how you keep people well, it's going to be all about what I talked about, of diagnosing things earlier and treating them and figuring out if there's a predisposition. But I didn't even get into the ethical concerns about taking a drop of blood from a baby and being able to tell what their propensity is to get every disease over the course of their lifetime and kind of predicting what their lifetime health is going to look like. And what does that mean for the insurer if they get a hold of that information? What does it mean for their employer if they get that information? How do you keep that private in today's world where every day there's a new giant company that's been hacked? Those are the kind of things that we're going to have to be careful for. Go ahead.
Yeah, I just mean, do you think that the like new healthcare system, especially in Florida that you're familiar with, is conducive to more medical research, not just in terms of prevention, but in terms of research?
Yeah, if you're asking about Florida specifically, you should all Google Lake Nona, N-O-N-A. It's outside of Orlando. It's a medical city where there's miraculous things that are being done. Sanford Burnham is based there. Their eastern site, California, is their first. There's a lot of big things that are happening there with medical research. We have a brand new VA, the second largest VA in the country. Of course, a lot of medical research occurs at the VA. We have the University of Florida Medical Research Facility is based there, and that's just one area. So yeah, in Florida, there's a lot of research that's going on. And you're here in California. I mean, there's more going on in California than there is anywhere in the country. So I feel great about where we're going to be in the future. It's just, the message I was trying to deliver today is just think about where we're going and all the things, all the Pandora's box that, that gets opened.
Thank you for your talk, Congressman. Not directly related to the ACA, but you mentioned at the start of your talk that you had some thoughts to share on redistricting and that process. You were effectively redistricted out of your seat before the 2012 election by a partisan process. If you have any thoughts to share on reform in that area or partisan versus independent commissions, love to hear those.
Thank you for that softball that you threw me. So I do have a very personal interest in redistricting, and you can all read about that if you want. It's instructive. But here are my views on redistricting. So this is interesting for you guys, and we took the tour earlier today where I saw a lot of your work that's being done on redistricting, and it's great that you all here at Claremont, McKenna, are so involved in it, and just the state of California doing unique things with these open primaries, which I think help to solve some of the problem I'm going to describe. But here's the issue with regard to another question I get asked all the time, which has the same answer I'm about to give, is why is there so much partisanship in Washington? And let me answer that question. It's really simple. Because we elect partisans. Our system is designed to elect people on the political extreme. And when you have people in Washington that don't look like the rest of the country politically, they're on the fringe, they look like the people who are on the political extremes, they are not going to have an incentive to work together. And the reason that this happens, see, most people, think about this, most people are normal folks. They don't wake up every day thinking about politics. They're not obsessed with it. They're worried about who's going to win the basketball game tonight. Who are the Seattle Seahawks going to draft in the draft? What time is my kid's activity tonight? What time does church start on Sunday? That's what they're thinking about. Where are we going to go on vacation this year? They are not thinking about what's my congressman doing in Washington today. And what I have found, my personal experience with this, and I have a fair amount, is the people who do wake up every day thinking about that, they have an unhealthy obsession with it, generally speaking. And they are often not the nicest people. And when you see them, those are the only people you encounter. They call your office and they show up at your events and they come to your town hall meetings. And it's great that people are active and engaged. I wish more people were. But when that's the only voice you hear, that has a tendency to impact the way you see the world. And when you go back to Washington, you're going to think about that. So when we draw the district lines, in most states, unlike California, it is a political process. And in Pennsylvania, it was a strictly political process. So you draw the lines to achieve a certain result. And in most cases, about 380 of the 435 districts fit this category. Think about that. The rest some are mildly competitive, and there's only a small handful that are really competitive districts every year, or every 2 years. You put all the Republicans in one side and all the Democrats in the other. And that's what about 380 of those districts look like. So what are the consequences of that? We're talking a lot about consequences tonight. Well, what happens is they don't have to worry about the other side. They don't ever see them. They don't ever hear them. They never hear a different point of view. And every time they go home and say, I voted 100% of the time with my party, they hear, right on. And don't you dare compromise. Go get them. Fight. So that's the climate that we have. That's not what the country looks like. I would say 85% of America looks like what I described earlier. They want us, when they think about politics, they want us to get along and compromise and negotiate and work things out and pass bipartisan legislation. But the reason that that's not incentivized is because the people who are actually serving in Congress don't see the world that way. To them, it's a game, and they're safe. They don't have to worry about their election. The only threat that they have is from the extreme, that they're not conservative enough or they're not liberal enough. That's the only way they can lose. And that has an unintended consequence. Oftentimes, those members don't feel the obligation to get out in their communities quite as much. and you don't have quite as much access to them, and there's all kind of policy issues associated with that. But from the redistricting perspective, think about how much different it would be if instead of having all these districts that are solid Republican and solid Democrat, we had that many districts that were 50-50, half and half. Think about 750,000 people is what a congressional district is, approximately. If you have a metropolitan area or a region with 1.5 million people evenly split among Republicans and Democrats, you have two choices for drawing that one line of how you're going to have two congressional districts. You can either make it 50-50, or you can put all the R's on one side or all the D's on the other. And think about the different type of member of Congress you get based on that one decision on how you're going to draw that line. You're either going to get two people who are never going to agree on anything. They're going to be opponents of each other on almost every issue. And they're never going to encounter different points of view. They're never going to see the other side even exists. Or you're going to get the 50-50 district, you're going to get two people who are in the center, who kind of see the world the same way. And one might be an R or D, and you're also going to see a lot more turnover because the political winds swing back and forth. And if you represent a 50-50 district, you're probably not going to be a career politician. At some point, the pendulum's going to swing the other way, and you're going to have more fresh ideas. All of that is good for the process. So what I say about the redistricting process is, instead of, some states have the law, I believe California is one of them, that says you can consider a lot of factors when you draw those lines, but you cannot consider political affiliation. Am I right about that here? I don't think you can consider whether you're Republican or Democrat. You can consider all kind of demographic issues. So I think it should be the opposite. I think you should be required to consider political affiliation, and you should be required to aspire to as close to 50-50 districts as you can possibly get. You can't do it in Oklahoma, where President Obama lost all 77 counties twice. You can't do it in Massachusetts. I get that. It's not perfect, doesn't work everywhere. But it works in a lot of places. It would work in California and Florida and Pennsylvania, I know that. So if you did that, you're going to get sometimes Republicans and sometimes Democrats, and the pendulum's going to swing, but you're always going to get people that listen to both sides, that have to vote intelligently and thoughtfully instead of just asking their party leader, well, how do you want me to vote? And there's too much of that goes on. So that's how you solve the redistricting problem. And by doing that, you also solve the term limits problem with people serving too long and getting new people into the system. Elections every year all across the country would be competitive instead of just a small handful in different pockets of the country. So you guys are involved in that right here. Think about that. That would be a great way to do it. And you would have a lot more consensus and bipartisanship in Washington, and you'd get rid of these kind of loud actors. And they have a voice. It's a great country. Everyone should be able to speak, but they shouldn't dominate the process. They shouldn't control the process because it is not representative of the rest of the country.
Thank you for your talk. I'm going to pivot slightly back to sort of healthcare. I am curious, I know a lot of what was going on in the discussion when the ACA was initially being debated with regards to cost saving was that it was going to shift from people relying on emergency rooms as their primary source of care to people using doctors more in terms of prevention, having regular checkups, things like that. I'm curious, from your perspective, what you think about the effectiveness of that, whether like you think that the shift is like, you know, effective or going to be effective, and whether you think that that'll solve a lot of the problems that both sort of individuals and healthcare companies and providers and like hospitals all have with regards to the overburdening of emergency rooms now.
Great question. And one of you a minute ago asked me what I thought about the law and what some of the failings were. To your question, the law is not strong on that point in discouraging the use of emergency rooms, and that gets into that whole cost and quality thing that I talked about. So the private market is getting involved in this big time. And when I talk about the interweaving of the different businesses, insurers and providers and some of the companies that are out there, the Walmarts and Googles, these are things that you're going to see change dramatically because the emergency room is the most inefficient least cost-effective setting you can get care. You can get good care there, but those other two things I just said apply. So when you have the opportunity where it's not an emergency case and you're driving down the road and you're looking for someone, or you're thinking about getting on that kiosk, you need to think about the implications of the decision that you're making, because when people receive care and it's not done the right way, there's an increased cost of that. But hospitals, importantly, use the emergency room to flow traffic and to admit people into the hospitals in most cases. So what you're seeing companies do now, and we're one of them in Florida, is open up emergency care centers. We have one in Orlando, about to open up another one along the I-4 corridor, right across the street from the hospital, very close to the hospital. So the incentive for this emergency care center is not to admit the person to the hospital, right? It's not to churn volume. It's to fix their problem, which hopefully is an emergency if they're there, right? I mean, that's what it's supposed to be. You don't want it to be utilized and the space taken up by folks who are in emergency circumstances. So when that happens, the hospital, through the competition that I talked about earlier, they have to adjust the way they do things. And then that competition starts. So as the insurer side, as a company that's paying for the cost of that decision that that person is making, getting into consumer empowerment, you want them to make the most intelligent decision for the circumstance that they're in. And that in a lot of cases is not to show up at the emergency room, if it can be avoided. If it's a true emergency and you're in the ambulance, that's a totally different story. But if you're choosing where you're going to go, make the appropriate choice. Does that answer your question? Got one way in the back here.
Hi, hello, and thank you for your talk. The way I see it, I feel like healthcare is moving towards a system where people that weren't previously insured and that weren't previously included in the industry are becoming included through the ACA. And as such, Obamacare has helped insure 12 million people in the nation, and that is obviously a really good thing for the way that healthcare is going. But even without those 12 million uninsured population, we are already having financial and managerial problems. Do you see any policy changes that we should make, or anything specifically that we should do in order to cater to these 12 million people?
Okay, I was having a hard time hearing some of what you said just because of the sound. So you were talking about what, 12 million people?
Yeah, so with Obamacare, Obamacare helped insure 12 million people that were previously not included
Correct.
in healthcare.
Yeah.
Is there, well, even without those 12 million people, we were already having financial and managerial problems. Do you see anything that we should do specifically policy-wise or system-wise that could be implemented to help these 12 million uninsured and the previously insured people?
First thing we need to do is get more providers into the pipeline, is to recruit people to get into the medical professions, not just physicians, but all medical professions, and allowing people to practice at the height, at the top of their degree, whatever they're most capable of doing, not shutting them off as some states do. Again, I don't know California's laws on this, but Florida has a really backwards law about shutting off the ability of certain practitioners to actually do what they're trained to do, which diminishes access and creates waiting lines and impacts quality of care. So when you have 12 million new people, and that number is going to grow exponentially, those are folks, A, who probably have lived without insurance for a while and have maybe because of that made bad health care decisions and may not be in the best shape comparatively to other people who have had insurance. And there's an issue associated with them immediately running out to get treated. And it's wonderful that they're doing that, but somebody's got to be there to answer the door when they show up. So getting more physicians into the pipeline has to be a part of the solution. And that is something that was a criticism of the ACA. We didn't deal with that in the appropriate way that we should have, because that's more of a training and educational issue. But that's going to be what people notice if we don't solve that problem, because it is going to be an access issue with all these folks who are new to the system. It's great that they have insurance now, but we've got to have the appropriate people treating them.
Time for one or two more questions.
I'm going to you gave it as an example. I checking my app on my phone to find 12 providers in the locality. My question is, as I make that decision, how do I know that which providers are better or worse? And my question to you is to comment on the ability of the AMA to really discipline providers who have proven to be less than qualified.
Are you talking about tort reform? Like malpractice reform too? Is that part of what you're getting at?
Well, in the orthopedic business of back surgery, there's I attended a lecture over at Casa Colina where one of the surgeons was telling about all the problems of providers who are less than ethical, in his opinion, of providing back surgery. So the question is, is the AMA, or how would you get the AMA to be more efficient or from state to state? Because providers can go from state to state and get relicensed.
Yeah, there are things that the insurers and the doctors agree on, and there are some that they don't, right? The insurance associations and the AMA. I think one of the things that we don't necessarily see eye to eye on are some of these payment reforms that I'm talking about. And some of them are going to help solve the problems that you're talking about. And I would certainly not, so you didn't do this either, but I would not suggest or want you to think that I'm suggesting that this is a rampant problem throughout the system. But there is fraud within the system, as South Florida in particular is notorious for healthcare fraud and billing errors. You do have a small number of physicians who are able to continue, which I think you're getting at, to survive in practice in the system by changing venues and changing states if there's been fraud involved, but also if there's been medical malpractice involved. And that's a huge driver in costs, is medical malpractice. So the AMA, playing a role in identifying and weeding out of the profession people who fit that description, which I do think is a smaller number. But those are things that the ACA doesn't do a whole lot about. Those are more things that the profession itself needs to self-police. And we can do payment reforms, and it's going to address part of that. But look, there are rules, and there are people who try to find ways to break the rules, and that's going to be in any business. And I think that the profession itself, AMA in this case, is going to be the one that's going to have to figure out a way to curtail some of those activities. Got one more here. I was afraid of this question coming up, so we'll see if.
Thank you for coming.
Yeah.
How does the big pharma play into this as far as new drugs coming out and having a really long patent process where how do we balance their right to make money and our right to get these drugs to the patients in the formularies and the different healthcare?
This was a huge issue when I was in the Congress, the length of patents. It's a big issue in California. Again, you all were doing more of this than almost anybody. So 20 years in the pipeline. And so the cost of prescription drugs, the question I get asked a lot is the merits of policy to cap the price of prescription drugs. Because if you look, just Google the rising healthcare costs by sector in the healthcare industry. And what you will find is almost every other sector in healthcare costs adjusted for inflation have remained pretty stable over time. And then you get to the pharmaceutical industry, and it's through the roof. It literally is off the charts. It's just exponential increase. And it's because of some of these medical innovations that I told you about. And when you have drugs that are working and that people want to have, and there's a market for them because they're saving lives or maintaining diseases in a way that we weren't able to do before, there's going to be a market for that. So the issue is the pricing of that and what that does to other insured people. So the pharmaceutical companies will argue that because almost every other country in the world has global budgets, they cap the price of drugs, that restricts the research, and therefore the R&D doesn't get done, because the one drug that turns out to be the one I just talked about, where you have a hepatitis C drug that's $1,000 a pill, and you take it and it works and it can eliminate the hepatitis, that's miraculous and that's a benefit to the system. But that was years in the making of R&D, of trial and error and failure, and eventually they got there. And the insurance or the pharmaceutical companies will say, well, the 9 out of 10 times that we do that we're unsuccessful, that it's a dead end, we need to keep trying that. And if you lock down, if you limit the patent process, we can't recover on the other end the billions of dollars in costs of the R&D that never succeeds. So that's a meritorious argument. There's something to that. But there's also something to the price gouging argument, where if you have something that nobody else has and people need it to survive, they'll pay any price. And if the insurance company is willing to cover it, just jack the price up as high as you possibly can. That is a big problem. So there's a huge battle in the industry now, the insurance industry and the pharmaceutical industry. And I spoke recently in Miami to the national conference of the pharmaceutical folks. And I challenged them, and I said, which is true, you guys are on the wrong side of this thing. You don't have the public interest at heart. And they know that at some point Congress is going to figure this out, and they're going to fix the problem for them. Or at least that is a likely outcome. Because that might be the only solution if they don't self-police, if they don't figure out a way to not just make people pay any price. So the pharmaceutical companies have an argument. Yes, we want to encourage R&D. We don't want to pass policies that restrict their ability to research and discover new miracles. But we also want to have an industry that is sympathetic to the cost and the impact that it has on the shift throughout the entire insured population and raising rates for everybody. So there's a push and pull going on there. But right now, the pharmaceutical industry is not doing their part. They're just running full speed down the track, and they are going to do whatever they want to do until probably Congress steps in. I think that's the only way this is going to happen. And they may set a cap on drug prices. I don't know if they'll set a cap on what we can spend as a country, which is what other countries have done, but they may set some sort of artificial cap on specific drugs and say you cannot charge more than this amount, or this amount over the cost of the research that went into making that specific drug. That's not good policy, I don't think, but if the industry doesn't do it themselves, that's what will happen.
Unfortunately, that is all the time we have. Please join me in thanking Congressman
Thank
Jason
you all
Altmire.
very much.